So, our first article was a symptom driven lorazepam protocol for treatment of severe alcohol withdrawal delirium in the intensive care unit. The level of evidence for this particular article and study was a retrospective observational study of a quality improvement project. The purpose of this study was to compare outcomes of alcohol withdrawal delirium with MIND's protocol versus non protocol benzodiazepine infusion, which was standard practice at the time, in an ICU setting. This is important that it's noted in an ICU setting because the CWA protocol that is used does not take into account patients that aren't able to communicate effectively, and it requires patients to be able to tell you what they're feeling, what they're seeing, what they're hearing, if they're having any of those symptoms of alcohol withdrawal or alcohol with delirium. So this was important to note that it was in an ICU to properly address those patients that aren't able to communicate effectively, like our ventilated, sedated patients. The method of this study was a retrospective study conducted at one VA medical ICU, and it compared the outcomes of patients that were treated 5 years before and 5 years after the MINDS protocol was put into place and used in this ICU setting. The results that they found were all pretty good. So, all decrease in time required to control severe symptoms, a decrease in the total dose of the benzodiazepine needed, and also a decrease in the time spent receiving a continuous infusion. So, all things decreased, all beneficial to the patient to not be on these medications as long as possible, and a decrease in the time required to control those severe symptoms is is important for the patient. And using this MMINDS protocol, the use of two or more benzos dropped from a crazy 94% to 17%. Like, that's a big drop, and I think it shows the benefits of using a protocol that is more appropriate for an ICU setting. Um, all good things came of this particular study. So the conclusion of this was that the protocol to treat alcohol withdrawal syndrome was found to decrease the symptom control, the amount of sedatives required, and the time spent receiving that infusion again. Um, all good things, nothing really to note that was not beneficial. So, yeah, M-Minds has proven to be a great tool for us to use in the ICU for those patients that we have that cannot effectively communicate with us what they're seeing, feeling, or hearing.
The purpose of this article was to determine the correlation between CWA-AR and M-MINDS tool in patients with alcohol withdrawal syndrome. M-MINDS is a modified Minnesota detoxification scale assessment tool. This study was conducted at an academic medical center where nurses were trained to use CWA-AR and M-MINDS tool. The nurses were blinded to the study hypothesis and administered both tools. M-MINDS scores were documented in the EMR, whereas CWA-AR scores were manually recorded. This study used Pearson correlation coefficient and defined a strong correlation if it was greater than 0.80, moderate if it was between 0.50 and 0.80, and weak if it was less than 0.50. A total of 185 CWA-AR and M-MINDS scores were collected in 30 patients. Across all 185 scores, the correlation coefficient was 0.82, which indicated a strong correlation. There were also strong correlations for tremors, agitation, and orientation. In conclusion, There is a strong correlation between the CWA-AR and M-MINDS tool, and even stronger in patients with CWA-AR scores of 10 or less. CWA-AR tool has only been validated in patients with uncomplicated alcohol withdrawal syndrome and has never been studied in patients requiring ICU level care, whereas M-MIND scores have been validated in ICU patients. When using the CWA-AR tool, it requires a patient interview in order to determine if they are at risk. Each parameter of this tool is based on a scale of 0 to 4 or 0 to 7 with a maximum score of 67. If the patient is unable to answer a question due to being intubated, CAM positive, obtunded, etc., they receive a 0 for that parameter, which can lower their score and affect their treatment. The M-MINDS tool does not require the patient to answer questions. The M-MINDS tool assesses pulse, blood pressure, and presence of sweating, hallucinations, agitation, orientation, delusions, and seizures to determine alcohol withdrawal syndrome severity. Since the M-MINDS tool uses more objective measures, it may be a better tool in the ICU patients.
A symptom-triggered benzodiazepine protocol utilizing SAS and CYAR scoring for the treatment of alcohol withdrawal syndrome in the critically ill. So this study is based on 167 patients. And its results just go on to emphasize the idea that CWA may not be the best option for our critically ill alcohol withdrawal patients. CWA is based on like fixed benzodiazepine dosing, whereas the SAS, Riker Sedation Agitation Scale, is more symptom-based dosing. So in the results, we found that using the Riker Sedation Agitation Scale, the patients typically had not only shorter overall length of stay in the hospital, but there were shorter lengths of critically ill time, shorter lengths of benzodiazepine usage, and also shorter time that the patients possibly needed mechanical ventilation as well. And that was in a direct comparison to CWA.
This article focuses on a study that tries to bridge the gap for patients suffering from alcohol withdrawal syndrome, or AWS. The hospital in this study uses an AWS management protocol that differs from CWA as it is specific for ICU patients. The implementation of the Yale Alcohol Withdrawal Protocol, or the YAP, was used in this study. The YAP pairs a modified Minnesota detoxification scale with an order set that includes benzodiazepine dosing regimens and suggests adjuvant therapies. The study wanted to determine that if an ICU-specific AWS tool was used, would that have a significant impact on the number of patients requiring mechanical ventilation? There were two groups identified in this study, one consisting of patients treated with the YAP protocol, and the other group was not treated with any medical protocol. Rather, their treatment of symptoms was physician-dependent. The outcome of the study showed that the group that was treated with the YAP protocol showed a significant decrease in intubations.
So we have some very specific recommendations that we would like to propose concerning the research that we've done. So number one, our primary priority is the patient. Our patients who come in on alcohol withdrawal, we want to make sure that we can give them the absolute best care possible. And the research today says that CWA for our intubated patients, our sedated patients, is not the best tool to provide that therapeutic care that we need. And so this really is all patient-centric. And so for us, we have a couple of very specific recommendations. So one, we are suggesting that the MIND tool be trialed in comparison to CWA here at St. Luke's. And if it does in fact show that we're able to more accurately track alcohol withdrawal syndrome in our ICU patients, that we would suggest that being implemented here at St. Luke's. If not, we would then also recommend that we go about trying to seriously find a proper tool for our ICU patients who are on ventilators or who are nonverbal, so that we can provide better care. I think at the end of the day that this is something that really could be of a significant benefit, simply because of the volume of patients we have who are on alcohol withdrawal, and that often as ICU nurses we really do struggle with. And so again, these are our recommendations, and we look forward to hearing your feedback.